Good evening, everyone. My name is Simran Chaudhary, and on behalf of Voice of Healthcare, I warmly welcome you all to the National Snakebite Awareness Mission, a virtual initiative conceptualized to recognize the International Snakebite Awareness Day. The event today has put up together by Voice of Healthcare and supported by Bharat Serum and Vaccines Limited. To address this crucial subject, we are honored to have an esteemed set of panelists with us today. Without further ado, let us begin with this summit. To begin with it, I would like to invite Dr. Rajan Mangesh, DGM, Therapy Specialist, Medical Affairs, Critical Care and Emergency Medicine at Bharat Serum and Vaccines Limited for the welcome address and to take this forward from here.
Thank you, Simran. And thank you. And it's an important issue that we are going to discuss today. Good evening, one and all. I'm Dr. Rajan, and I'm from BSV, leading a therapy specialist of critical care and emergency medicine. Today, we are gathered here to discuss an important neglected public health issue, snake bite, which needs an emergency intervention from multiple stakeholders for better outcomes. Let me give you a slight background. Globally, when you see there are around 1,40,000 snake bite deaths happening, with disabilities ranging 2 to 3 times higher. And in India, the situation is yet more alarming. With the deaths, snake bite deaths are half of the global deaths, and nearly 4 lakh amputations or disabilities happening annually. Today, we have a panel of experts from different fields who are here gathered to discuss on initiatives, solution, and update us on way forward how this can be better managed. These discussions will range from awareness, education, ASVS development, future advancements in the management from small molecular therapeutics to recombinant, and very importantly, the role of technology in managing the snake bites. Without much ado, to take it forward, I would like to welcome Mr. Jose Lewis, a wildlife conservationist, CEO of Wildlife Trust India, and has an extensive experience in snake bites and snake bite mitigation strategies. Over to you, Jose.
Thank you, Dr. Rajan. May I have the screen, please? Yeah. Thank you, Dr. Rajan. And you set the context very clear and very effectively in front of all of us. And without much further introductions, I would like to get our keynote address speaker, Dr. Ajit Shivale, Joint Director, Center for One Health, National Center for Disease Control, Government of India. Dr. Ajit and team is pioneering and spearheading, along with many other things, many other initiatives which they are doing. They have taken up the snake bite as one of the major things which his team is doing. Let's hear from him about the scenarios of snake bite in India, the current scenario, and the government initiatives.
Very good evening to all. And first of all, I would like to congratulate the Voice of Healthcare for organizing this important webinar on snake bites in India. And today is the International Snakebite Awareness Day. This day is organized to spread the awareness about the snake bites, the prevention of snake bites, the collaboration between the stakeholders so that they can join the hands for prevention of snakebite mortality in India and across the world. So it is very important that such a webinar has been organized where we can all share thoughts, and those who are listening to the webinar, they will get insight onto what needs to be done for prevention of snake bites and also the management of the snake bites. So if we see the snake bites in India, we all know that snake bites in India is a very significant public health problem, and mostly because it's an life threatening. It's because after the bite of the venomous snakes, and when they occur, the venomous snakes bites occur, it can result into the snake bite envenoming, which is known as envenoming means the systemic complications because of the venom which is being injected into the human body. So it can result in the severe paralysis, which can result in breathing issues. It can result in the bleeding disorders because of the snakes, which cause hematoxic effects and lead to the hemorrhage. It can lead to long-term complication in terms of irreversible kidney failures, limb amputations, and severe local tissue destructions. So we can see that it not only causes a mortality, but significant morbidity and also the disability. So not only these three impacts, but it also results in psychosocial complications because following the snake bites, many people have that post-traumatic stress disorder like symptoms. So this is a holistic impact it has on the human life, and it needs to be addressed in a such a way that these interventions reduce all these four spectra of issues which are caused by snake bite. If you see the global burden of snakebite, it depends on the prevalence of medically important snakes. So India has significant the presence of medically important snakes. We have more than 236 varieties of the snakes, and among them, more than 15 are actually uh, medically important, means which actually cause the systemic envenoming. And few of the parts of the other countries, they also have the significant medically important snakes like Australia. But if you see the envenoming, it is very high in Asia and particularly in India and neighboring countries because of the presence of some local cultural factors and the socio-ecological factors and the epidemiological factors, mainly because people are living in close vicinity with the snakes. The cultural practices such as that they do not approach the health facilities, and lack of access of health facilities also responsible for the increased deaths and increased envenoming cases. And if you see the data which is collected under integrated disease surveillance program, now that portal has been changed to the integrated health information platform, we can real time see the location, the districts, the block, the of that particular case which has occurred in the country. So both cases and deaths, the data is collected from the block level through the PSCs and through the health workers, frontline health workers, that is ashas and ANMs. Then the if you see the gaps and challenges apart from this, we have, apart from the reporting, we have another issue of poor ambulance and pre-hospital care. We have to address that because the events are occurring at odd hours, at odd locations, which results in that transport to the particular health facility makes it very, very important. And for that particular issue, the 102 and 108 ambulances, they have been instructed to take the patient as soon as possible to the health facility, nearest health facility where ASV is available, anti-snake venom. And this is a particular issue we are addressing it through our program. Another issue is about the polyvalent antivenom issue, which targets currently the four species, which is cobra, Russell viper, soft-scaled viper, and common crate. But for range restricted species which are occurring in other parts of the country, northeastern and north states, we are working that we should have the regional venom centers which can prepare the antivenom which is locally suited for that particular incidents occurring in that area. And lastly, the most important part is the community awareness. So prevention of snake bites, how to prevent the snake bites and what is the first aid after the snake bite, that is very important. And for that we have undertaken few efforts in terms of spreading the awareness. So these are the this is there is a program, that is a national program for prevention and control of snakebite and venoming, that MOHFW is providing the support to the states under the National Health Mission for undertaking the activities of trainings, the strengthening the emergency care services, and the surveillance, the IEC activities, and the intersectoral coordination with the key stakeholders. One of the important part which we should know that although India bears the maximum burden of snake bites, India is one of the first country to develop the national action plan recognizing the impact snake bites has in community. So we have developed a national action plan which targets that the snake bite deaths should be reduced by half by year 2030. And not only Ministry of Health is included, but Ministry of Agriculture and Farmers Welfare, because the farmers are important stakeholders. And apart from that, Ministry of Environment, Forest and Climate Change, along with the other ministries and organizations, they are involved in this particular action plan. And this was launched in 12th of March 2024.
Oh, thank you very much. And as we are the leading um, affected country with snake bites, the government's initiatives in the recent years, it's very clear that the central government and various state governments has taken up snake bites as a priority issue, and a number of initiatives at national level and state level is taken by various departments, including the health department, the forestry department, and many other departments. So there's a synergy happening between these departments addressing this problem, where we are losing about 50,000 people. Losing 50,000 people to a snake bite is definitely a challenge, and it needs a lot of cooperation, and it needs a lot of help from various sectors. So, with this, I would like to invite our next speaker, Dr. Vinita Srivastava from the Ministry of Health and Family Welfare. Probably one of the most diverse person when I looked at her CV, which was shared. She's a lawyer, she's a social worker, she's a hospital management expert, and she worked with the ministry for a long time, and she's still with the ministry. She led a lot of missions, and she's here with us to discuss about the snakebite and climate change, how communities are affected, and how prepared we are to deal with snake bite and imminent. Dr. Vinita, welcome you on behalf of everyone.
Thank you so much. I have a small PPT which I will like to show because my topic was about the tribal communities, right? So, what is the tribal community perception? And I have been while working with the document for NABCAC, National Action Plan for Snake Bite and Worming. It was very helpful for us. And while developing this, I came to know that so many things are to be known to people, which is very important. Can somebody can share the PPT, please?
All right, Dr. Vinita. The PPT is online. I can see it. And if Khushbu can take control over the PPT, please.
So, can you see the slides, please?
Yes, Doctor.
Yeah. So, uh, so when we talk about tribal community perception and awareness of snake bite and worming, it's something very different because as I was hearing Dr. Ajit Sekwale, who was here, and when we were talking about what are the challenges, beliefs, and pathways for effective treatment when we talk about tribal people. So we all understand because important that snakebite is a serious and potentially fatal condition that occurs after bitten by the snakes. It is known, and it is much we have seen that, and I mean I myself has seen in the interiors what happens. So we all understand that in India it is estimated that 3 to 4 million snake bite occur each year, and accounting for half of all snake bite fatalities with around 50,000 deaths, which we recently heard from Dr. Jeet. But did you know only a small portion of snakebite victims across countries report to the clinic and hospital? The actual burden of snakebite is grossly unreported. So, which is very important. Why I'm saying this? Because I've seen that whether the deaths were reported in these facilities or not, but they were not. So, this was also a challenge to us when I was in tribal affairs, and this make me learn that how what is the problems across the country. So, as but the Central Bureau of Health Investigation reports the average annual frequency of snakebite cases in India is around 3 lakhs, and about 20,000 occur due to snakebite and worming only. So, what is the challenge? So, the question arises despite these deaths, why aren't we able to control the snake bites? This is the challenge. Now, when we talk about cultural perceptions of snake bite in tribal communities, it's very important that we have to understand their mental stigmas, what are there. So, snakes are often seen as a sacred and symbolic in tribal traditions. We all know that. Some tribal view snake bites as the spiritual punishment or omens. Cultural beliefs may delay seeking medical interventions. If you kill a male snake, then the female snake will take revenge on you. They have this feeling. And what about the traditional remedies and practices? What, because they are much into this, so what they do, they have their own practices doing it. They rely on the traditional healers, herbal medicines. Common practices include applying herbs, chants, and rituals to neutralize the venom. While some traditional practices offer comforts, they do it, but they may not prevent complication or death, but can further increase complication. And the application of a harmful method as the first aid for snake bite is very, tourniquet is very known to people. And further, poverty comes become a barrier in accessing modern medicines and facilities. This is again a very, very challenging thing that poverty really hurts them. Lack of education makes it more worse because they are illiterate, they are hardly knowing about, they haven't hardly seen the schools, so that things makes the things more worse. Awareness and mistrust in modern medicine is again a big challenge, because what happens, mistrust in modern healthcare delays in proper treatment. They don't have that trust. Why the trust is not there? Distant from medical facilities, as Dr. Ajit said, that lack of transportation further complicate access to antivenom. In research, it was shown that private hospitals do not admit snakebite cases, that they do not have snakebite treatment facilities, while government hospitals do not take care of properly because there is a long waiting time and non-availability of doctors during emergencies such as snake bites. So if you, as he said, that it happens in night, it is a problem to everybody, and there is no, we need to have doctors or nurses trained in a manner that they are able to treat these snake bites. Limited education on dangers of snake bites, disability, like they don't understand it impacts. If it happens, it impacts and effectiveness of antivenom. Unaware of rescue remedies in regard to. So they don't know what to do exactly. When we talk about training, are we supposed to train our community people also? Difficulty of claiming health benefits leading to further erosion of trust. Now, when we have these health benefits packages are there, claiming health benefits are there, but they hardly get it. One or two cases happen such like that, so they have a mistrust on the public facilities. Now, what challenges in identifying venomous snake species? Tribal communities often struggle to identify which snakes are venomous. Community members believe that snake venoms alter the taste sensation. They mentioned that green chilies or dry chili powder, salt, sugar are given to the snake by a victim to eat, and there is a loss of taste, and they consider the bite to be venomous or vice versa. So these basically uh, struggles are there, and fear of all snake venomous or not can result in confusion and panic also. So it is again a challenge. And when we talk about what is the roadmap, when we know about all these facts and factual, what is the roadmap? So roadmap, when we talk about short term, I have taken up short term measures and long term measures. So short term is very immediate first aid, such as mobilizing the limb and avoid full harmful practices. They should know about it, emphasizing to reach the medical facility for antivenom as soon as possible, and mapping of high risk areas and action for prevention and control of measures accordingly. These high risk areas to be, this can be done very easily. Any like, we have Voice of Healthcare, where we have many agencies who can help us, or even Serum India can help us in mapping these high risk areas. So long term strategies, when we talk about, is basically community based awareness program, which we were saying, but it is cannot be done in one way. Only the medical education department can do it. So educate, like we have this national action plan for prevention and control of snake bite involving in India. And so this has to be taken up. Now tribal leaders and tribe has can be they can be a bridge between the tradition and modern medicine. Preventive measures, like they can be taught for prevention of wearing protective clothing, surroundings, recognizing venom escape. Developing trust in public health facilities is very important to us. Now, what happens when I was just going through the tribal areas, and here when I was talking about in NHA, because we also have a package of health benefit package for snake bites as well in the National Health Authority. So Inclusion of snake management in the training, state public health departments is important. Short-term training for medical graduates. So now this MBBS kids are there. They should be taught about this. And induction training on joining the state health services in India. They should know about these things. These are the facts and factual what exactly India needs. Skilling of tribal youth about the snake bite prevention and management. This is again a very important day because if these youth can help us, it will be very helpful for the long term. Local medical officer for training and capacity building at local level. Collaborate with tribal healers, environmental experts to develop strategies to reduce human interactions, and local venomous and non-venomous spray by developing the regional local specific IC. I always say that it should be in tribal languages, it should be in local languages. People should know about it. If we are only going to talk in Hindi and English, it's not going to help us in, especially in the remote areas. Tribal departments to be actively involved in awareness campaigns, as we said, that it is a synergy program and it needs. So this is where again every department has to come forward, whatever wherever they can be helpful. Provision of patient transport, which is like bike ambulances, is very helpful. Involvement of community social worker in claiming benefits. This is again when they go for the benefits claims, they don't get it. If we involve somebody as a social worker in the community itself, it will be very helpful. They will have a trust in our public health facility, which is not there. Healthcare facility needs upgradation, that's very much. And development of telemedicine is again a. So what we did, a small project I did it in one of the interiors. We trained some of our community people, community youth people, and they were very helpful in taking up the telemedicines as well. So these and cost of extracting venom for production of antidotes need to be decided and published. This is again, they say we do a lot things, but government doesn't come to us to give us up a help. We do the extracting venom, or we do or everything, but none of the government comes forward for us. So we have to make a trust, which trust is lacking. And this I have seen in my own visits through these states. In many states I have seen. So I would like to show the references because I have gone through these things. And my only concern, which I'm really worried about it, that the public trust is very important. We are losing trust. And until unless we have trust with our people, and they have trust in our facilities, it is not going to help us. And whatever the government has done till date is a big thing, but again implementation is a challenge because we are not able to bridge the gaps, which is very important. And now being in NHA, I was just going through the 2.0 health packages, which is very important for us. We are having the snakebite packages also, but people are not aware. So who's going to tell them that now this is the time that people should know about what exactly has to be done? So with this, I end my presentation. It's a small presentation, but I just wanted to say some few things which were very important while I was in tribal affairs, and it has helped me out in learning about the problems which we have faced across. It will be great. Thank you so much.
You're on mute, Jose.
Thank you, Dr. Vinita. It was a short presentation, but it was a very powerful presentation. You touched some of the very important things and often not much talked about things like reaching out to the tribal communities. And of course, India being a country of diverse culture, background, people, snakes are part of our culture, our beliefs, our tradition, our mythology. So we can't, I don't think that in any way we can take away snakes from our culture and our symbolisms. So they are revered, worshipped, and at the same time feared by tribal communities and other people. So it's very interesting. It's it's an eye opener when we look at some of the topics which you talked about, the challenges of reaching out far and wide, and also ensuring that the tribal communities also get the benefit of healthcare initiatives such as anti-snake bite programs. Thank you, Dr. Vinita, for such an insightful talk about the challenges and the way forward. Definitely, where you are with the ministry, your involvement, your help, and your guidance will be very much helpful to all of us to take this program forward. Um,
My learnings with tribal affairs, my learning with health, and my learning with the patients. I mean, those who have got disability. It was really a eye opener to me. These people
we
have
can
got.
really see that human connect in your conversation. That's highly appreciated, Dr. Vinita. From Dr. Vinita, from the tribal issues. Now we have somebody with a lot of experience in forming the policies of the country. We have Dr. Urvashi Prasad with us, um, who actually told me that I'm a passionate public health professional. Very simple. Somebody who worked with the Niti Aayog, India's leading platform, where the policies, the vision for the country, the future vision is formed, developed, and implemented and advised to the other government agencies. We have Urvashi Prasad here. Good evening and welcome. The screen is yours.
Good evening. Thank you for having me here. And I'm glad I've finally got into my Wi Fi connectivity. So hopefully you can hear and see me fine. So I think we've already had some, very insightful remarks and presentations. So I'll just, limit my comments to a few important issues that, I would want to highlight. I think, firstly, this is very rightly back from 2017 in the WHO list of priority neglected tropical diseases, because in 2013 it was removed from that list for some reason we don't know. But in 2017 it came back into category A of the neglected tropical diseases. And I think, as has been outlined, that given the tremendous, not just mortality, but morbidity, people who get disabled, people who have to live with lifelong morbidities due to snake bites, it rightfully deserves to be in that place. And obviously, as we've also discussed, that there is a huge burden in South Asia and Africa. So I think for these reasons, in developing and poorer parts of the world, I think it's very important that this status came back for this condition in 2017. But coming more specifically to the Indian context, I would say that the first and foremost important thing is data. And we do have some data around snake bites, but it is quite imperfect. And most of us who work in public health know that it's not a very precise estimate, and it's important for various reasons. It's important to for operational reasons, to be able to plan, where is your anti-venom requirement the highest. How do you plan for that? How do you plan the supply chain, the logistics, etc.? So who are really the communities affected? As we heard, that there are certain especially vulnerable populations, tribal people in rural areas, obviously people of poorer socioeconomic backgrounds, agricultural workers, and children. Children also, as we know, are very, very vulnerable, because it's difficult for them to sometimes even understand, what has happened, or even report a bite. So I think data is important for multiple reasons, and so we need to improve our data systems. Of course, this is true for most public health issues, but very, very true for this particular issue. The second aspect, I would say, is, of course, we need to create this awareness amongst all these highly vulnerable groups. Like I said, even for children, for instance, we need to have that kind of awareness and that understanding of the snake bites, venomous, non-venomous. It's quite difficult for a layperson to be able to understand all of this. And of course, added to that is the mix of, the superstitions and the myths and the misconceptions. So there's a lot of work to be done on that front. And I think we need targeted strategies for these different vulnerable groups to be able to create that awareness effectively. And then I think the third dimension is of the healthcare workers training. and making sure that they are aware of this challenge. They, of course, have access to what they need to. Like I said, the anti-venom availability itself is something that becomes challenging in many, many areas. And that's why I said data can help with a lot of that planning. But I think also training otherwise in terms of how to just handle these situations, because we know that a lot of times it might not even be the actual bite, but what happens after that, results in either the morbidity or the mortality. So I think training of the health workers, we have now uh, also these health and wellness centers which have been set up under Ayushman Bharat across the country. So we can also leverage those. We can, of course, and we should leverage our network of health workers in rural areas. So I think there's a great amount of training which has to continually be done. And some of it can also, of course, be done remotely. We can now utilize technology to do a lot of these things. And I think lastly, I would just say that we need to, as I said, anti-venom, that's one part of it, but we need to prepare the entire infrastructure, especially in the rural areas, to be able to handle these kind of cases. There need to be very clear standard operating protocols which are understood by people, which are understood by health workers, because we have a lot of these things in principle, but we need to take it down to the last mile, because that is really where the need is, and that is where most of the victims of snake bite unfortunately are. So I think from a policy point of view, from a public health point of view, these are some of the very important issues that I've also been working on as a public health professional. And I think things have happened, but there's a lot that we still need to do, and we really need to try and prevent and better manage as many of these cases as possible, because it's something which is very, very doable, if we have the right kind of systems and the right kind of awareness. So I hope that we'll continue to focus on it. So I'll stop here and look forward to hearing from the other panelists. Thank you.
Thank you, Urvashi. And this is what we need. This is what is the need of the hour. The think tank, the policymakers sit and develop and guide the country with the right policies. And these policies are what the bureaucrats and the rest of the machinery can implement. And definitely, you talked about the last mile connectivity, where we have to reach all these things, all these interventions. And I think our next speakers are sarpanches from two different states of the country. One person is from UP and the other person is from Orissa. And these are recorded conversations. And I had an opportunity to look at these conversations, and it's really, really, I must say, shocking, or I must say eye opener. Like, what is the actual last mile connectivity issues which we are facing? I would like to invite two sarpanches. I say that these are representative of people from two different parts of the country, and over to them. Please, can I have the video, please?
गांव में ये सांप की का चर्चाएं का ज्यादा लोग हमारे यहाँ का बहुत समस्या आती है। जो हमारी खाई नदी है, खाई नदी के पास हमारे गांव नीचे ऊंचे जमीन है, तो ज्यादातर इसमें लोगों में सांप निकलते रहते हैं। कई लोगों को सांप काट गए तो बाईगिरों के हिसाब से बुलाया जाता है और झाड़ी फूके दे करके, और उनको उसी हिसाब से ठीक है। कई लोग हमारे यहाँ मर चुके हैं इससे। तो हमने किसी कंपनी द्वारा ये हमको जानकारी मिली है कि इसकी भी कोई वैक्सीन या दवाई चली है। इस वजह से हम अब ये वीडियो को देख करके हमें ये अपनी सरकार से और उससे लोगों से ये चर्चा करनी है कि इसकी दवाई चली है, वैक्सीन चली है, इससे फायदा हो सकता है।
सबुठारु बड़ समस्या होची स्वास्थ्य सुविधा। बहुत दूर रे आम गाँ ठारू डाक्तरखाना अच्छी। जेते बेले साप कामुड़ा हुए तुरंत चिकित्सा पाई डाक्तरखाना पहुँचवा कष्टकर हो जाए। यही कारणरू विष शीघ्र व्यापी थाए एवं जीवन प्रति विपद हो जाए। साप
Um, I hope some of you could understand the first Hindi version, and the Oriya version. I got a translation. Actually, I think we could not play the translation part, but I would like to bring your attention to that first part. A pradhan of a sarpanch of a village is telling that today I came to know that there is a medicine to treat snake bites. I have people dying in my village, in my area, due to snake bites, and I just came to know about a vaccine. I mean, definitely it's not a vaccine, but a treatment method is available to save people, and it is his request to the community and the rest of the machinery that they need treatment. And it is the classic problem which we face all parts of the country. There are gaps. If we find the best anti-venom, if we have the best hospitals, but how are we reaching these facilities to the people who actually affected by snake bites? The second person was from Orissa, and I'm very happy. I'm very, very, very happy to tell all of you that recently I was working with the Orissa State Forest Department. The State Forest Department and the State Disaster Management Authority has taken up snakebite as part of the new government's 100-day mission. It's such a commitment which is the government is doing. They have allocated the resources, they've made plans. If I'm not mistaken, one of the DFO who's involved in this program is also attending it. I told him that I have an interaction with the experts here. So there are states taking initiatives, but everybody is talking about the sarpanches are talking about the last mile connectivity, the need for reaching out to those villages. I'm going back to what our previous speakers were telling, Dr. Vinita and Dr. Urvashi was telling, the need for reaching out and reaching to this last mile and reaching out to these people. I would like to invite Dr. Umesh Bharati, who's a renowned expert on various interventions. His work in containing rabies in Himachal Pradesh has already won him a number of awards, including Padma Shri, and he is a very leading he's a leading authority on snake bites and other animal bite related issues in the state of Himachal Pradesh. And I would like to invite him to talk to us about the scale of the issue which he is facing and the barriers which they are facing in his state. Welcome, Dr. Bharti.
Can you see my slides?
Not yet. Yes, you're online.
Yeah. Can you do it full screen? It is full
You're on full
screen?
screen, doctor. Yes, please go ahead.
Can't see it full screen. Anyway, so in 2008, no, I just a very nice story. I knocked at the doors of the forest department to know how many snakes, venomous snakes they had. They said we don't have any study on the snakes of Himachal Pradesh. Then I went to the NHM. They had no funds. There were no training, no guidelines. Total blank. Everything was blank. No SB at the PSC level. No studies on snakebite. No collaboration with the forest department. No community awareness generation. So it was such a bad situation when and actively in 2008 I started looking for some solution to the snakebite. So then a PG student was assigned to me. So I took the opportunity and asked him to do a secondary data analysis of Solan district. And we were surprised that majority of the snake bites were green pit viper. And the anti-snake venom was not working on green pit viper bites, despite giving 100 vials. And the patients were remaining, their BTCT remained, blood remained unclotted, and there is no effect of the anti-snake venom in green pit viper bites. Majority of the bites were green pit viper. So this understanding led me to in one of the meetings. This of the sorry, there is some disturbance. So in one of the national guideline meetings, I I shared these findings, and I was able to convince the stakeholders that we should write in the guidelines that we should not give anti-snake venom for green pit viper bites. And to your surprise, thousands of vials were saved all over the country with just one line in the national guidelines. So this is how you go from a local level to a policy level. So this is a publication, anti-snake venom not working. And then I was assigned a project of 108 ambulance service in Himachal Pradesh, whereas I forced the ambulance provider to keep anti-snake venom in the ambulances. And to my surprise, not only poor people were saved, very rich people were also saved. Even lonely people at home were saved from death due to availability of anti-snake venom in the ambulances. So then we published this paper in one of the journals, one of the small journals, and later on I convinced the service provider, EMRI, they kept these anti-snake venom in 16 states of the country. You imagine thousands of people were saved all over the country. And this is the publication that is highly cited in WHO publications, transporting snakebite victims to appropriate health facility within golden hour through toll-free emergency ambulance service in India that saves lives. Then, in the meantime, God gave me opportunity to collaborate with Bangor University, and that opportunity I utilized in identifying snakes of Himachal Pradesh. So we are a team of 4 or 5 people led by Dr. Nita Malhotra from Bangor University Geology Department, and then we mapped the snakes of Himachal and identified the 7 venomous species of Himachal Pradesh and rest of the non-venomous species of Himachal Pradesh, and made a documented it and gave it this booklet to the forest department. And we published this. We also analyzed the green pit viper venom that was not being neutralized at all by the current Indian anti-snake venom, but it was being neutralized by a monoclonal antibody from Thailand. Green pit vipers made anti-venom monoclonal made from Thailand. It was neutralizing our this green pit viper venoms. So this is a publication, and again highly cited publication. Then we started looking for the data of the snake bite deaths in Himachal Pradesh, and that was brought to the notice of the authorities that we don't have any system of data collection. Only 30 deaths are being shown, while we know more than 100 people die. And in the meantime, we published a paper from Madhya Pradesh in collaboration led by Priyanka Kadam, and you will see the data issue was raised by our planning department, ma'am. Uh, the data in the data that was showing a very few deaths, like say that actual data was 9 times higher. See, the figure of 2,846 people who were given compensation due to snake bite death in Madhya Pradesh, that was 9 times higher than the data of the 330 deaths in national health profile. So this is a very good indication that we should now focus until we have real figures. Go to the compensation due to death due to snake bite all over the country to have immediate response and immediate data how many people die, because we give more we have more people getting 9 times more people getting actually death compensation than shown in the reported data. So this is another area that need to be looked into. Then Dr. Danny John has done a small study out of pocket expenditures. There's very high, range from sometimes from 0 to more than 4,000 US dollars, and that's what I think it should be exclusively included in the Prime Minister uh, uh, welfare Prime Minister PMJ Jan Arogya scheme, or local health government health schemes. That snake bite up to 4 lakhs you can spend, that should be included exclusively, so that people get the benefit of no what is the use of giving 4 lakh rupees after death until we spend that money on treatment. That is what I that is another area. So we made a awareness booklet in Hindi, and put all the snakes and gave it to the forest department and to all the panchayats, to all the doctors, paramedical, asha workers. uh, this is in wide circulation in Himachal Pradesh, and detailing all the myths that is prevalent locally in Himachal Pradesh, how to dispel them, what is the reality and what are the myths. Then there, we collaborated with the forest department for training of the frontline staff of the forest department how to rescue the snakes and how to release them safely in the forests. This is Vishal Santra giving the training. So these were very good initiative of collaboration. And then school children being given awareness posters. So all through the we printed these posters and we distributed to identify snakes and how to prevent them. So all everything was there. Now we have uh, and moreover, when there was no money for trainings, whenever we got the opportunity, we started giving trainings to the doctors, because at that time there was no program in place. Then a PILY NGO were filed in the High Court, and then High Court directed to keep ASB and anti-rabies vaccine in all up to the PSC level. So that geared up the government no to keep no refrigerators up to the PSC level. Then then we got this national-wide study on snakebite death, disability, and economic loss to generate data how many deaths are there, led by Dr. Menon, and no, I am the national co-PI. So this study is a really milestone, and we have already results are coming out, and maybe very soon we will publish these results. And these deaths are very high, more than 45,000. Then these guidelines were published and distributed among all the doctors. And there is a very interesting story. When I got this award, and I was called by Health Minister Mr. JP Nadda, congratulations. Then he asked me what else you are doing. I said I am doing something on snake bite, but nothing, no breakthrough is there. Then he asked me to send him 2 pages, on one on rabies control and one on snake bite control. So I sent him 2 pages, and similarly, when I got a opportunity to meet at home in one of the at-home ceremonies, so I met the Prime Minister and I handed over those 2 pages to him. And to my surprise, the action mode was there after those 2 pages were given, and that's how this National Program for Prevention and Control of Snakebite and Envenoming was born. So I'm so happy that now it's no, it's in full fledged. So I really am thankful to the Prime Minister and the Health Minister, who is now currently Health Minister, that they have really taken this no, seriously and put every system into practice. So now I just finally I want to focus what are the gaps and where we what we should do. So one is as everybody said, mass awareness campaigns for rural areas through radio, TV, and TV to prevent snake bite, and then involvement of local community and local snake rescuers. Then trainings of local faith healers, then hands-on training of medical officers of the PSCs, availability of anti-snake venom, glass tube, laryngeal mask airways, embu bags, injection atropine, neostigmine, able oxygen up to PSC level. You won't imagine it. 2 rupee no glass tube for 20 WBC test is not available in the PSCs. So they should be as an essential part of the essential list of the medicines and equipments. They should be available at the PSC level. Then separate snake bite management room should be there. Otherwise, the IUC, no, emergency always full of people, and then when snake bite patient comes, he or she doesn't get a ventilator. Then anti-snake venom in transport ambulances should always be there. And to identify snake bite hotspots, as somebody said, no, we should know where is the snake bite happening and what type of snakes, venomous, non-venomous. They should be identified. Mapping should be there, so that we immediately know that this area patient comes and that would be a venomous snake bite. Then compulsory reporting of all snake bites, and then free treatment in case of snake bite and cover it under PMJY up to 4 lakh an amount equal to death compensation. So better to compensate people while they are living on treatment than after death. So that they are the some of the hot points that I would like to share. Thank you very much.
Thank you, Dr. Ramesh. That was again an interesting thing, and also giving us some insights about how initiatives like yours manage to bring the political support. But that's very important. Our political leadership should understand about the problems which are faced by people, and this kind of intervention, this kind of one-to-one interactions with senior political leaders is what will actually open doors and catalyze changes. So thank you on behalf of a lot of people. Thank you for opening up these doors and bringing snakebite into the serious concerns of the ministers and the political leaders. Thank you, doctor. And
Thank you.
with that kind of studies, and also I would like to tell the viewers that their study actually gave us an insight about the snake species in Himachal Pradesh. And none of us in the wildlife field or snake field thought that you can find a good population of Russell's vipers, which is one of the most venomous snakes in the country, is available in higher elevations of Himachal Pradesh. This was like again an eye opener, and also probably an indicator of climate change and the way the snake is adapting to a terrain which we never thought that it will be surviving. Anyway, doctor, thank you very much. And I would like to invite Dr. Raut, who's a Pune-based doctor. He and his wife treat snakebite victims in their hospital, and they have a number of victims from the rural background. And this experience of him and his wife, where they treat snakebite victims, is actually he will be sharing his experience as a practicing doctor about the challenges which they face in treating snake bites, about the practical approach of snake bite management in a hospital. Over to Dr. Raut, and may I have the video, please?
Dr. Sadanand Raut. I am physician from Narangao, and we have started a Mission Zero Snake Bite Death since 2000 and saved more than 12,000 snake bite victims successfully. We have started this mission initially with in a many odd conditions, but now we are successful, almost working for more than 25 years. The three pillars of this mission are to provide effective and immediate treatment to the snake bite victims. Second pillar is there is massive public awareness. Third pillar is to provide training to the doctors in surrounding region. Initially, there are many superstitions. People were going to the mantrik or temple after the snake bite, and they are doing wrong primary aids. This cobra bite patient was admitted within 20 minutes after the bite. She had a bite on the both middle finger tip, and while throwing the garbage. She was brought in 20 minutes, but still she reached in a cardiorespiratory arrest. Pupils were dilated. We resuscitated her successfully for 45 minutes with injection atropine, injection neostigmine, injection adrenaline intracardiac, IV fluids. We infused 20 vials of anti-snake venom within 20 minutes. She is intubated immediately and kept on the ventilator. She recovered. She started some signs of eyelid movement and toe movement 3 hours after the treatment and ventilator. She recovered fully without any neurodeficits. So early transportation and aggressive resuscitation is very important in case of cobra bite victims. Another example is cobra bite with pregnancy. This patient had a cobra bite in the house, and her husband informed me. And they are staying 60 kilometers from our hospital, away from our hospital. So, in spite of calling to them to our hospital, I sent them to the nearest primary health center and given instruction to the medical officer to start ASV 10 vials, injection atropine, injection neostigmine after clinical examination. But he had given only 2 vials of anti-snake venom, injection atropine and injection neostigmine, and the victim reached to our hospital in cardiorespiratory arrest. So proper doses in neurotoxic snake bite with our protocol, 10 vials, you must start, finish, and then refer the patient. This is another example of superstition. This 6-year girl was brought to our hospital 5 days after the crate bite. Crate was killed. She was on a ventilator. As she was poor, they referred her to our hospital. We have started regular treatment, and she was comatose at the time of admission. Pupils were dilated, not reacting to light. Deep gels were also absent. Her GC was very poor, but we have treated her on ventilator, antibiotics. Fortunately, she recovered. She became conscious after a few days. She was moving upper limbs, lower limbs. She was playing with the mobile. But some mantrik or relatives told them that the girl is not going to survive. In spite of we are treating her freely and she is recovering, the relatives took discharged against medical advice, and she died on the way to hospital. So still there are many superstitions regarding the management of snake bite in remote areas, and we have to do massive public awareness.
Thank you, Dr. Raut. Thank you, Dr. Raut. You just highlighted the need for the right treatment. What we talk in snakebite treatment strategies, we say that the right time, that the first case, that you have to reach the patient within the shortest possible period of time to the hospital. That's within 20 minutes a patient reaching to the hospital. And the right place, that's another challenge in India, that which hospital to go for snakebite treatment, because in not all the hospitals, not all the private hospital, not all the government hospitals across the country is ready to or equipped to treat snakebite patients. So we have experienced, we have witnessed, sometimes helplessly witnessed the situations in rural India where people actually search for the right hospital to treat snake bites. It takes time to reach the hospital, and also the right dose of antivenom. You need antivenom, and you need other supporting medicines. So what we are talking about is the right treatment. And of course, as Dr. Raut was telling, that even though the right treatment, the right hospitals, everything is available, how the superstitious beliefs, how our traditional beliefs, how culture and tradition overpower these things, and patients often fall victims of superstitious beliefs and treatments. Some cases are very sad to hear, some cases are promising, and I wish we have, and I really hope that we have more such promising snakebite successful treatment cases from various parts of the country. Now I would like to bring Dr. Dayalmandu Majumdar, a practicing medical practitioner from West Bengal, a state which has got large number of snakebite cases. Dr. Majumdar is a veteran in the field with a lot of experience, decades long experience, and also very committed towards this cause. So in my interactions with him over telephone, whenever I asked him for help in his state or neighboring areas, he was always very happy to help. Let's hear Dr. Majumdar from West Bengal about his experiences dealing with snake bites in West Bengal. Over to you. To Dr. Majumdar. It is a recorded
The most
conversation.
common mistake
Audio,
done by the
video, please.
is with the common crate snake bite. Common crate snake bite. What's the problem with common crate? Is that common crate snake bites are painless bites, and there will be no bite mark. Painless bite, and there will be no bite mark in 99% of cases. But what common people know, that there must be two bite marks. There must be two bite marks to be a venomous snake bite. Whenever a doctor come across with a common crate bite patient, he diagnose it looking towards the other neurological signs, but not the bite marks. But what common people do the mistake, they search for two bite marks like this. This two bite marks theory is the most dangerous misconception among general people. But what happened in my patient, he stepped over the snake in the open sunlight in his garden. But due to this misconception that there will be a painful bite, there will be bite mark, there will be swelling like this, he totally ignored that bite. And he went to the hospital about 20 hours after bite. And he deteriorated to total respiratory failure. Another atypical case, due to this concept, you have to forget this concept that venomous bite must be two bite mark. Venomous bite must be with swelling. Venomous bite must be with pain. No. You see, this single bite mark, this is also due to a cobra bite mark. There may not be always two bite mark. There may not be always immediate pain and swelling. This older patient stepped over something in the paddy field, in a bush of grass, and he felt that like a thorn pick where he is pointing with the pen. There was a thorn pick like sensation in the afternoon. He totally ignored that because there was a skeleton of a dead dog. He thought that the tooth has been pricked here and it was not a snake bite. He totally ignored it to be a case of snake bite. He thought it to be a prick by the dog tooth. But after 3 hours, there was swelling and some pain. And he came to the rural hospital, and a lady doctor suspected it to be a case of snake bite. She had done 20 WBCT, that is clotting test. The 20 WBCT was not clotting because actually it was a case of Russell's viper bite.
Well, thank you, Dr. Majumdar. And with the connectivity issues and other things, we could not get him online full time. But I think this classic misconception about two bite marks, that's probably really a dangerous one, because the two bite marks can be only seen in movies. Probably, our movie makers are responsible for this, because all the nagging characters in Indian movies, Bollywood movies, were very particular about giving this two bite marks on their victim's body, and it became a rural belief, and a lot of people still believe that two bite marks should be seen. When I interacted with the rural communities, they still refer to some of the old movies and say that nahi nahi aise nahi hota hai, dono daant ke mark hote. And it is also thanks to some of the earlier wrong training programs or wrong designs or diagrams which were used. They're all, it was showed as two bite marks, two fang marks. That's a real misconception, and a snake bite can be just a scratch or a random wound, or you may not be, as Dr. Majumdar was telling, in crate bite cases you may not even see a bite mark. So these are misconceptions, and people who are watching this online, please educate people around that snake bite, you need not to see those two fang marks. It can be just a scratch, or you may not even see a scratch. If the advice which is given by all the snake bite experts, doctors, are in case of doubt, please go to the hospital. Whether you have seen the snake or not, if you have even a doubt about that this is a snake bite, please go to a hospital. You don't need to worry about whether it is a venomous snake or non-venomous. That's the doctor's responsibility to do the tests and tell you that whether it is a venomous or a non-venomous bite. Please don't look for bite marks, or try to identify the snake. Just go to the hospital. Okay, with that, we got our next speaker, Dr. Sushant Thomas, from rural Uttar Pradesh. He is a medical officer in Kachawa Christian Hospital in Mirzapur, where he is handling more than 500 plus snake bite in his hospital. And during the interaction, he informed that major problem is awareness, people reaching hospital on time, people reaching with the proper first aid. So he is talking about the need for first aid and also awareness, and also his experience as a practitioner treating snake bites in rural UP. Video, please.
For the challenges in rural India, this is something that I would like to share with you. Being part of this rural Indian hospitals for the past 2 to 3 years, I would like to share that the challenges are real and are hardcore in this ground reality. And one would be the late access to the nearest health facility is a big stumbling block for most of our patients. So, as I was telling, we have approximately 30 cases of broad dead patients who come to our hospital, and most of them come from 50 to 60 kilometers away from our place, and some even come from different states like Madhya Pradesh and so on and so forth. And they say that they do not have a proper nearest health facility like a PHC or a community health facility where adequate ASV is being provided. So this should happen at the governmental level, where all the community health centers are provided with, especially in these endemic areas. Providing adequate ASVs at the community level is the first line of improvement, first step forward in our management per se. And the second aspect, especially again in this rural part of India, would be the traditional malpractices with the traditional healers that we come across that is wasting precious lives. And in our part, it is these practices are called the jad fook. So basically, they take the once the patient is after having these their bite, they go to the traditional healers, they do certain practices, and then we lose a precious amount of time in getting the patient proper adequate health education at the very local level, at the gram panchayat level, is the way forward for us.
Please,
Jose, you're on mute.
Thank you. I follow this thing very particular that I unmute, mute, and I forget to unmute. So thank you, Dr. Thomas. We heard three doctors from different parts of the country, four doctors from different parts of the country. Looks like we have some similar challenges, reaching hospitals, the traditional healings, the misconception about the snake bite, the misconception about anti-venom, everything. We do have similar challenges across the country. Now we are moving towards some of the solutions. Yes, now it's very clear that we do have certain problems in our hand. And I would like to invite Dr. Shashwata Banerjee from Bharat Serums to talk about the snakebite challenge, and also being an anti-venom manufacturer. What is the need for a coordinated action? It's not just the anti-venom, but also multiple things, multiple support systems are needed for successful snakebite management. Over to you, Dr. Banerjee.
Yeah, thanks, Jose, and very nice discussions which are happening. So, as being a physician as well as from the manufacturer side, so I could actually see the both the aspects of the snake bite management. Thanks to all the speakers who has covered the magnitude of the problem, the challenges, as well as the what are the realities in the ground level to manage these cases. Now, when we talk about the snake bite, we always talk like it is an neglected disease, and there are a lot of areas which are required to tighten and develop, which can actually uh, create a kind of an environment where the snake bite cases will be managed more efficiently. Now, thanks to the NCDC as well as the One Health and Government of India for coming out with the guidance document for the overall strategies, how we can reduce the death to half by 2030, as well as the overall burden disabilities for the snake bite related. So they have adapted the principle, the four pillars of the snake bite management, rather I would say the prevention and control of the envenomation, as well as achieving towards the goal, which is the death, reducing the death by 50%. So the four pillars, if I just describe in this way, which is adapted from the WHO snakebite envenoming roadmap objective. The first is the safe and effective treatment. Of course, that has multiple elements how we can achieve the safe and effective treatments. Second is empowering and engaging the communities, because it cannot be achieved without the involvement and empowering them for the involvement for the communities. Coming to the third pillar, which is the stronger health system. When we say stronger means we have to definitely put a lot of more facilities, starting from the training of the healthcare professionals, the support staff, the paramedics, the diagnostic kits, and of course the availability of the main core, the line of the treatment, which is the available safe and effective anti-snake venom serum. And thanks to all the manufacturers who are being part of this endeavor, and BSB definitely is one of these, and serving to the entire nation, to the entire society for more than last 25 years, starting the journey of the manufacturing of the anti-snake venom from 1999. So I am happy to be part of this, the endeavor. The fourth pillar is actually partnership and coordination and the resources. So when I tell about the partnership, coordination, and the resources, of course the WHO has given a lot of guidance to that. That what are the elements which can actually give kind of a partnership and coordination and the resources, starting from the feedback mechanism from who are practicing the core healthcare professionals at the district level hospital, rural level hospital, and also the tertiary care center. That what are their challenges, how the drugs are working, or the other alternative therapies which are coming up in the coming days working. So how these are their experience, so in the form of different feedbacks, and these will reach to the the different research institutes, the policymakers. They will start exploring that what are the better solution we can look for, so that the treatment becomes more efficient. So it is the partnership between the NGOs with the healthcare professional, the research bodies, and the manufacturers like BSV. It could be even the wildlife conservationists, the climate change experts. All of them are the important stakeholders for this entire mission, and they all should come up and the uh, create a kind of a community form, which I happy to see that this is happening here exactly the way it should happen, and we should then achieve the goal. So I'll just end my the presentation, or rather that what I wanted to tell, with some of the initiatives that BSV has taken over last a few years. Of course the product is being manufactured and you know distributed to the across the country in different locations, but uh, from a futuristic point of view, what can still be done from a manufacturer like BSB? Of course, we are the therapeutic solution provider. We have the polyvalent antivenom, which is designed against the big four as being the standard of care snakes in our country. And we also create a lot of scientific programs, the awareness programs among the HCPs, which is based on the evidences, which is we call it as an evidence based management of the snake bite victims. These actually empowers the HCPs to learn newer things, also the researches which are happening, and also the guideline based approach to the snake bite cases. Now the new things are coming up in very recent times, even in the NAPSI document which Dr. Sevale has covered, that the recent understanding of the inter and the intra-species variation of the venoms of the geographically spaced species of the big four are identified. There are a lot of research works. My following speaker, like Dr. Karthik Sunagar, and many other researchers across the country, they are working on this. They are, try to find out that what are the different, the species, the variations in the venoms among the different species, which are, spaced out in the regions. Like, the venoms of the west are not same like the venoms of the east of the same species of the snake. So that creates a kind of a resistance of the venom which is currently available in the market. So that has given all the manufacturers are working, and BSB also is a front runner in the entire endeavor. And we have conducted the first of its kind of study, which will address both the geographical and the species level variability of the snake venom. and happy to collaborate with the central medical the research institute like ISC. And we have got extremely good support, and rather we are very proud to be partner with such institute, estimate institute of the country. So we aspire to develop the broadly reactive, preservative free, and next generation antivenom which are region specific. So the ministry is trying to set up their the venom collection centers across the countries in the 4 different locations. As soon as this process will be completed, the venom sourcing will be more smooth, and it will help the manufacturer to get the species variations, the venoms having the variations as per the geography. And we can also we can also create more definitive product. There are many researches are going on the monoclonal antibodies, the the chicken antibodies from the venoms. I'm not getting into it, but in a nutshell, if I just say that BSB has an aspiration to develop the regional snake venom, the purification strategies which are employed to the manufacturer, which will be as per the latest WHO requirement, and of course in line with the IP requirement of the country, as well as the quality and standard, which are the BSB takes care of that with the I would say that most important the pillar of the quality of a product, which are mandated by the CDL and all the regulatory bodies. And of course, I feel like with all these initiatives, we can fill the lacuna in the present snakebite management. Thank you.
Thank you, Dr. Banerjee, and that talks about the research, the scientific research in the field of developing more efficient, more potent, region-specific antivenoms by our own manufacturers in India. And also would like to tell you that the challenges of sourcing venom in many states, this was a problem which many of all the antivenom manufacturers faced. I think now the state forest departments are more forthcoming, and there are policies which are helping everyone to ensure that regional specific antivenom manufacturing or researches can be conducted. My next speaker, whom I actually missed in the previous session, is one more doctor, Dr. Anup Kumar from Kerala, who is again a practicing doctor who is treating snake bites. A short recorded video by Dr. Anup about practical approach in snake bite management in the state of Kerala. Video, please.
Physician in North Kerala. I am actively involved in snakebite management for more than last 15 years. And in our experience, some other changes what we made in recent years are the accelerated regime of ASV. So as we all are aware, our national protocol recommends for especially for hematotoxic envenomation 10 initially, then after 6 hours 5, then every 6 hours 5 to total maximum of 25. But in severe bite cases with initially itself having severe coagulopathy or severe signs of envenomation, and in those cases, or if the snake is already identified as one of these big fours and having these severe envenomation, so we give initial 10 vials, and without waiting for next 10 vials, we give other 10 vials also in the next hour, and then we wait for 6 hours. Then we give the third 5, so total 25 vials. So this accelerated regime we are practicing nowadays, especially with severe envenomation. Another thing what we are practicing nowadays is, especially after giving this ASV, if patients are still having significant DIC or like a refractory capillary leak syndrome, or something like a microangiopathic hemolytic anemia. So those cases we found that the plasma exchange, especially high volume plasma exchange, is very effective. So I think in last 2 years we have done at least 10 plasma exchanges, and almost all patients we were able to rescue. So I think that part also has to be included in our guidelines, and probably we are collecting those data, and we are in the we will publish those data as well. Another issue what I usually notice is in emergency department, the when they are doing this 20 minutes whole blood clotting time, so majority of the time or sometime they may misinterpret, or the test tube may not be properly dried, or there may be some soap particles, and there may be a wrong interpretation, or there may be a false positive 20 WBCT, or 20 WBCT may not clot even after 20 minutes, but the patient may not be having envenomation. So those situations, the one practical clue what I've learned in last few years are, in majority of the snakes in Kerala or in India, which produces coagulopathy, will be having local reaction also. So the only so in those cases, if you are still having a doubt that the 20 WBCT is relevant or not, see whether the patient is having a proper local reaction or not. If there is no local reaction, then better to recheck the coagulopathy or 20 WBCT once again and make sure that it is proper. Or you can keep a control also, then see whether the 20 WBCT is proper.
Thank you, Dr. Anup. And I know Dr. Anup personally, and he is here online also, I suppose. Many cases, in case of emergencies, he is the person who I connect with doctors across the state or in neighboring states about snake bite treatment, especially Russell Swiper bite cases. He is very helpful and he is very actively helping people. My next speaker is Dr. Karthik Sunagar, a great friend. And I call him the most venomous person around, because his entire life probably is dealing with the venomous things, scorpions, wasps, and snakes. And he's the man who's done path-breaking research in venoms and understanding the regional variations of snake venom. And his studies is a world renowned scientist in the field of venoms. And it's my pleasure to invite Dr. Sunagar to this talk. And over to you, Dr. Sunagar.
Hey, thanks, Jose. I'll just quickly share my screen. Can you please pull it up? I've shared my screen. Yeah. Hi everyone. I'll try to be as non-technical as possible. But today what I hope to tell you is how snake venoms change in India, and what are we doing about it? How do we solve this problem of snake venom variation? Just to give you a brief background, so I had this evolutionary venomics lab at Indian Institute of Science in Bangalore. We are mostly interested in understanding ecology and evolution of venomous animals. But a major focus of our research is also on snake bite, because as you have heard from the previous presentations, it's a highly neglected tropical disease, and it's the poor people of India who suffer the brunt of it. So we not just work on snake venoms, we work on all kinds of venomous animals, as Joe's just mentioned. And previous presenters have also told you about the burden of snake bite in India. Over 58,000 people die every single year from snake bites in India, and over 50% of all the global deaths due to snake bite happen in India. That's why it requires a solution. The current solution for treating snake bites is using antivenom, which is produced by hyperimmunizing equines, horses, ponies, and mules, collecting the resultant antibodies that these animals will produce against these venoms, and then administering them into snakebite victims. So we have already known this for a very long time. For example, when we looked at these four populations of rattlesnakes in the US, these populations were very close to each other. You can see that one of them was neurotoxic, whereas the others were hemotoxic. And the antivenoms were actually being made using the hemotoxic population. So it was not very effective against the neurotoxic one. So when we looked at the venoms, that's when it became clear that these different populations of the same species can have very different venoms. But ignoring all that, we have been producing antivenoms by collecting venoms from a single point location in southern India, and this antivenom is used for treating snake bites all across India. Now we know that this antivenom is not very effective in countering snake bites here in Karnataka because of, although it's a neighboring state to Tamil Nadu, because of the evolutionary histories of these snakes. So there are lots of things that we need to account for when we are designing these snake bite treatment strategies. We also know from research that almost 90% of a vial of antivenom actually contains antibodies that are not therapeutically relevant, meaning they're not really useful for treating snake bites because these antibodies could be directed against viruses, bacteria, and other antigens that you find in horse blood. So you require many vials for treatment. In India, antivenoms are not very expensive, but in some parts of the world, they can be super expensive and they are unaffordable to the poor people who get bitten by snakes. And because you require lots of antivenom vials for treatment, you can imagine you are administering a horse antibody into a human. So human antibody would respond to that horse antibody by raising antibodies against those antibodies, right? So this is called a secondary reaction. Sometimes it can result in anaphylaxis, which can also lead to dangerous, life-threatening situations. So current antivenoms are made using a strategy that was designed over 100 years old and has virtually remained unchanged. So there are lots of things that we need to change about the current antivenoms. And as you have heard, the antivenoms only target 4 snake species in India: the spectacled cobra, Russell's viper, common krait, and saw-scaled viper. But there are many other snake species which are medically relevant, as you have heard from some of the speakers. So since I started this lab some 6-7 years ago, we have been going around to all corners of India and collecting venoms of snakes from the wild, and then looking at the venom compositions, seeing whether current antivenoms are capable of neutralizing these bites. Um, so we not only collect venoms from the big 4 snakes, but also the other medically important snakes that might be found in regions. So in the interest of time, I'll briefly tell you, without explaining the studies, about the venom variation that you find in Indian snakes. So there is a lot of geographic variation in venoms. So for example, if you look at fingerprints of cobras from different parts of India, this is a paper that we published a few years ago. We now have complete profiles of all medically important snakes from all corners of India. So you can see that there is extensive variation in these fingerprints of venoms already, right? Even neighboring states can have very different venom compositions. But as I said, we now have these profiles for Russell's viper, for kraits, as well as saw-scaled vipers and other medically important snakes. So the bottom line here is that there is a lot of variation in terms of geographies of these snakes. That is, different populations can have very different venoms. The venoms of the same population, different individuals in the same population can also be very different. So we looked at this monocellate cobra population in eastern India, West Bengal, and we looked at different individuals, venoms of different individuals, and we saw so much of venom variation that the antivenom would work effectively against some individuals but not against others. So the variation even within individuals found in the same region can be quite stark, and that's something that is very least studied. Venom can actually change as these animals age. So for example, younger snakes can have very different venoms from as they grow older. So we conducted this study on Russell's vipers, and we showed how venom becomes more complex as these snakes age. But interestingly, the baby snakes actually had much more potent venom than their mothers. The snakes that are just born have twice as more toxic venom as their mothers, which was very interesting. So what is the consequence of all this venom variation? Again, this is not an updated figure, but what we see is that these antivenoms they do save lives, but they are poorly effective in many parts of India, and that needs to be addressed immediately. And so one of the strategies that we have been following to address this problem is producing a regional antivenom, as one of the speakers pointed out earlier. So what we did is we went out and collected venoms from a couple of regions in Western India, and we didn't choose these locations randomly. They were chosen based on our previous studies on what are the medically important snakes that are found in regions and how effective or ineffective the antivenoms were. So based on this, we collected venoms of not just the big 4 snakes, but also the other medically important snakes in these regions. And now we are making a regional antivenom that we are testing in the lab now. The immunizations were carried out by Bharat Serums, and they produced these antivenoms. But the major solution to snakebite is a universal antivenom. So as you have heard already, snakebite is not just problem of India, but it's a problem that's much more prevalent in Southeast Asia, in Sub-Saharan Africa, and many other places. So we are also trying to develop an antivenom or an antidote that would work across continents. And I can show you some of the promising results here. So what we did in this particular study is that we targeted one of the most prominent toxins that you find in cobras, kraits, black mambas, king cobras, and so on. And I'll not explain the science behind it, but this involves state-of-the-art immunological strategies where you produce these antibodies in the lab in mammalian cell lines, right? So you don't really require immunization of animals. You can produce these antibodies in the lab itself. And so one of the antibodies that we discovered in this process, in collaboration with Scripps Institute, was capable of neutralizing venoms of different snakes across continents. For example, this graph shows that if you inject venom into mice from these crates, they all die within 4 hours of injection. This is just one component of the venom. But when you mix it with our antibody, you can see that these mice survive post 24 hours. They are perfectly fine, as you'll see in a video later on. And this one antibody, in comparison to millions of antibodies that you find in a vial of antivenom, this is just one antibody which targets one component of snake venom, and it was capable of neutralizing venoms from snakes across continents in Southeast Asia, in eastern part of India, and in sub-Saharan Africa. So why is this a major breakthrough? As I told you, current antivenoms don't work across borders, political borders, but this antibody works across continents. It is highly dose efficacious, meaning that each vial will contain almost 100% of this particular antibody because you are recombinantly producing it. It is inexpensive because you don't have to immunize thousands of horses and maintain them. It is a human antibody, so your immune system will not even recognize it as a foreign antigen. So it also solves that problem of secondary reactions. And lastly, it is ethical way of producing, treating snake bites, because you don't need to immunize animals anymore. You can produce these antibodies in the lab itself in culture plates. So this was actually published on the cover of Science Translational Medicine, and that's a cobra that I photographed not far from my lab here on campus. But I'll also show you some of the work that we are doing in the lab here in Bangalore to address this problem of snake bites in India. So we now have a wonderful solution for treating Russell's viper bites across India. So again, I'll not explain the science behind it, but these are again human camelid antibodies. So these antibodies are from camels, but they look like human antibodies. I'll not explain the technical details, but let's call this antibody 10x. I'll directly show you the effect of this antibody or how effective this antibody is. So I'll show you videos of mice that are injected with Russell's viper venom. We are injecting them with 5 micrograms of venom, which is almost 5 parts of 5 micrograms is a lot less. So you can see that just within 2 minutes of injecting this Russell's viper venom, mice start dying, right? So it just takes 2 minutes for Russell's vipers, or even lesser sometimes, some populations, to kill mice. But with our antibody, even 24 hours later, you can see that these mice survive perfectly fine. And again, this is antibody made in India, and this antibody is perfectly working in treating snake bites or Russell's viper bites across all corners of India, except in some places where more than one antibodies are needed. Now we have other antibodies, similar antibodies, which are targeting cobra venoms, Russell's viper, saw-scaled vipers, and even kraits. So the future of snakebite is producing antibodies in the lab and not immunizing and harming animals in industries. And finally, we are also looking into small molecules and other solutions. So these small molecules are basically pills like crocin that you can take in the field without probably clinical help from a clinician or a doctor, because you can just take it like a crocin tablet. And we have found certain combinations of small molecules that again work perfectly well in countering snake bites across different parts of India. I'm not showing that in the interest of time. And finally, I'll just show you a picture of my lab at IASC. And thanks, Joe, and thanks, organizers, for the invitation.
Thank you, Karthik. I really don't know whether you give the good news or bad news, or when are you giving the good news and when are you giving the bad news. Like you almost scared all of us with telling us that the problems of the current antivenoms, or how. But still, we are treating people. This is the only option we have currently in this country. The antivenom is saving lives, but research like what you are doing, or people like you, are really ensuring that a number of snakebite incidents in the future will be just like a fever or just another injury. I mean, the last few words of yours, like a crocin or a small tablet you take their antivenom medicine. I really I don't think I'll live that long, but I would like to see that we have such medicines, such wonderful medicines, which are there to save people from snake bites. Um, Thanks, Karthik, for doing all this work, because I met you long back, and I have seen your lab, and when it was just walls and few desks, and from there to here, I know you have invested a lot of your time, energy, and other resources, and I can we all can see the great commitment and the great science which you are producing in this country. It's a matter of pride that we have assets like you in this country, who will lead the fight against snake bites across the world. And this is also promising that we have manufacturers, companies, who Shashwat just spoke few minutes back, the company's efforts to bring more potential antivenoms. So it is nothing that we are not losing anything. We are every day we are working or moving towards snake bite mitigation and finding better antivenoms, better treatment methods, etc. Without losing much of time, I would like to invite my next speaker, who is um, I really don't know how to introduce Dr. Jaydeep. I call him as a good doctor friend, and literally I trust him with my heart, because he's a cardiologist with 25 years of experience in preventive cardiology, and a very well-known cardiologist in the state of Kerala, but also is a leading snakebite expert in the state and also in the country. And he's part of the national task force, where they're studying the mortality, morbidity, and the socio-economic burdens of snake bites. Not just the doctor's duty, but also understanding how it is affecting communities. And he is also the leader of the ICMR designated Center of Excellence at um, snakebite research in Amrita Hospital in Kerala, um, and is a visiting professor at Howard School of Public Health in UK. Welcome, Dr. Jaydeep. Very happy to have you here. Over to you, Doctor.
Thanks, Joseph. Thanks. Any question to me?
No questions, Doctor. You can talk about the use of technology and the latest trend in treating snake bites, especially your experience. We would like to hear from you. What is your studies? What is your experience? Talk about snake bite management in the state of Kerala.
Let's first start with the digital technology. Digital technologies made a lot of inroads in all aspects of patient care, or rather in the
Dr. Jaydeep,
continuum
can
of
we have
care.
your camera on, please?
I'd rather not switch it on,
Okay,
Jose. It's
fine.
so digital technologies made a lot of inroads in most aspects of medical care, in the continuum of care. Say, suppose for surveying for disease, monitoring of disease, prevention of complications, etc. But probably not as much in the field of snakebite. As you would know, the neglect extends to even the digital technology not finding inroads into snakebite envenoming and its treatment. So what all technology is already available in this field as of now? So when you look at the issue of snakebite, you could divide it into three. One is the snake and its product, that is the venom. Second is the host, that is either bee or cattle or livestock that get harmed by the snake. And the third is the environment, which decides about the animal human conflict, or the snake animal conflict in this case. Also, keeping in mind that snakebite is a neglected tropical disease, and it shares space with 23 other diseases, but snakebite kills more individuals than all the other 23 diseases put together. And snakebite is also the number one cause of mortality, animal human conflict. Snakebite far outnumbers all other causes of animal human conflict, whether it is for livestock or whether it is for humans as well. So, keeping this as a background, what can we do by way of digital technology in actually improving what we have? What we have right now is we have an ambulance network where which lays out an app, actually tells you as to which the nearest center, whether it's in the public space or in the private space, that actually treats snakebite. It has the human resources as well as the material resources, that is vis-a-vis ASV, available on hand for treatment. So this kind of a network is there in a few states in India, not only limited to Kerala, it's also available in a few other states as well. You have a few apps for the identification of snakes, which is very, very useful as far as uh, the communities, as far as the community is concerned, in the sense, if one spots a snake in the garden, is able to take a reasonably good photo, especially of the head. These apps actually tell you what the species is. At least, if not the species, at least it tells you whether it's of the venomous, the medically relevant snake or not. Now, you have different sites like the IUCN, or you have the same site that you run called the indiasnakes.org, that actually tells us about the snake sightings and snake rescues and the captures across the country. So when you look at the snake human conflict, there are certain drivers for this. These drivers include the density of snakes, the density of the human population, how crowded it is, the environment, vis-a-vis how dry, arid it is, or how wet it is, or what the elevation, etc. is. It also depends on whether you have continuous flow water, that is, you have a canal system run of flow, in which case you have cultivation throughout the year, or whether it is through the riverine systems, or through rainfall that one depends on cultivation, which would be seasonal, as also how much of the percentage of population is agrarian, uh, how many people are hunter gatherers, how what is the forest cover in that particular district or the state, amount of rainfall. All these, there are 13 factors that actually weigh in on your likelihood of snake bite. So if you can populate the senses that we collect on bite with the sightings, we can come to some sort of a roadmap or a hotspot mapping as far as snake bite is concerned. Now, you have different awareness videos and other information, communication, and education material on various aspects in the context of snakebite, whether it is with identification, whether it's the do and don'ts of bitten, or whether it's on the preventive aspects of snakebite. And this is across states in different languages. This is plentifully available. So all these are part of the digital technology. But what I would the concern really is that whatever research is being done actually is concentrating on the treatment aspects, as also the venom aspects of it, in which basic scientists actually look at the variations, venom, etc. All this is definitely very important, but what we tend not to research as much is about the snake. What are the habits of the snake? What is the forage area? How frequently does it feed? What are the feeding practices? And what would be its forage distance that it covers, etc. So for me, a lot more studies have to be done in the snake bite, especially vis-a-vis its behavior and habits, to sort of be able to prevent this human snake conflict. And the radio tagging and the telemetry program for king cobra was excellent. The same could be done for other medically relevant snakes, especially in the northeastern parts of the country. I think that would be of great value. uh, does that help, Jose? Anything else that you'd want?
Absolutely, Doctor. That not just help, but that helps a lot, because you almost spoke like a wildlife biologist, and what you said is the correct thing. That when I was attending a couple of meetings about human wildlife conflict in the wildlife circle, it was the tiger, elephant, rhinos were on the top of the list. And I remember it took Dr. BC Chowdhury's effort to literally get the snakes sneaked into the list of animals which could be killing people. And the wildlife experts were really shocked when we told them that snakes actually kill more people than all the other animals put together. Your tigers, leopards, elephants, rhinos, everything together probably killing about 500 people across the country every year, probably. But we do have information. We do understand that snakes kill more than 50,000 people. People like me who are wildlife enthusiasts or wildlife people, we talk about human wildlife conflict, but getting snakes and snake bite into the line of human wildlife conflict. It was a tough task, but when it reached the human wildlife conflict scenario, people are now understanding that snake bites actually is a serious challenge. And this actually helped many state forest departments to come forward with plans and projects and initiatives to reduce human snake conflict, because the end of the day snake bite is considered as a wildlife attack. And many places we told them that if you really want to bring the human wildlife conflict down, the numbers down, then you better focus on snake bite deaths in this country. That's a good thing. And also you mentioned about the digital technology which we use. So we do have mobile apps. So we have Serpent mobile application, which is currently on your screen. You can download the app, which can help you to navigate to the nearest hospital. We have about 3,000 hospitals listed where antivenom is available. And also we have rescuers listed. And also you can take a photograph and send it to using the mobile application. We can help you to identify the snake. So there are a number of such technologies which is available within the country, which is reaching out to far and wide of the nation to ensure that people do get some sort of help in case of an emergency. My last speaker, but not the least, is the probably the youngest one in the lot. It is Ganeshwar, and I met Ganeshwar when he was very young, and I've seen him growing up and working in the field of snake bites. I think with a lot of passion. Currently, he is doing his PhD from a UK university and working with the Madras Crocodile Bank, and he is part of the national task force in snakebite mitigation. Gani, we are proud of what you have done as the youngest wildlife person here, and your contribution towards countering snakebite, and also you're the IUCN representative in country. Over to you, Gani.
Okay, am I audible by any chance?
Yes.
Oh, perfect. Yeah, I think I owe a lot to the people who are right now in the panel and few who are off the panel for me to be here and be able to speak about this. Of course, being at the tail of these conversations gives me the privilege of just summing up a lot of what's been already discussed, and also takes away the burden of re-explaining most of the concepts of snakebite. But yeah, from the background that I work for, we work mostly on what happens before and after the snakebite incidences, on how do we prevent the problem of snake bites, and how do we sensitize communities that are possibly facing the wrath of this problem. And again, the problem doesn't end with treatment alone. At most points, there is also a problem with the way people claim compensations, the psychological trauma, and further relating back to the circle of fear and anxiety in the communities, leading to again the same old practices. A lot of work that we do circles around awareness and outreach. And of course, we've also been training forest department staff, rescuers, and being able to handle snakes safely. Most of you might know that one of the biggest risk factors, or rather victims of snake bites, are snake rescuers who do not handle snakes well. And in the sake of social media fame and sometimes a little bit of excitement, they get bitten, and this usually becomes fatal if they're bitten by a venomous snake, because the proximity at which they're handling snakes gets them a really nasty bite, keeping them at par. So we are picked up from what Jose and his team has done in Kerala, the SERPA model, and now we are implementing it across the country in about 15 states, where we are going about training some of the staff of the forest department and some of the established snake rescuers, and standardizing the way that they catch snakes. And these guidelines were developed from friends such as Joe's, Jerry Martin, folks from MOFCC, and some international experts, of course, overseen by my direct supervisor, Romulus Whitaker. And we're now reaching out to communities, we're reaching out to snake rescue networks, and standardizing these training practices. We ensure that the authority remains within the government, within the forest departments, Only that way there is supervision over what's happening in locally. And as an implementational agency such as us, the Croc Bank, we only provide services that are mainly helpful to the forest departments. Similarly, we've been conducting outreach activities. I was just talking to a friend early this morning of how we have been doing outreach for about 4 states in this week, where we are going to schools and going to villages and conducting preventive materials, conducting information on prevention, first aid. We've been doing films. As you know, going to a village or to a school and sitting and conducting a presentation, doing a talk on with a presentation may not usually help. So we've been relying on films which are drama oriented, keeping the people on loop, and we've also produced some songs and music which helps children to get going. Maybe they will not understand the lyrics of it, but it gets them hyped up. So we are backing a lot of our preventive methodologies using social science, and that's helping us a lot in understanding how communities respond, different to the regions, different to the age groups, different to the gender sometimes. And all these materials are being used in policy making. I think that's where our role for the NAPSE has been acknowledged, is where we've been bringing in the diversity of the problem and diversity of the solutions that are required. And here, as most of you know, that a victim who reaches a hospital has a very straightforward requirement, whereas a victim who is not a victim already, they have different kinds of requirements that we need to address, and we cannot really impose information onto the heads. We cannot continuously talk to them about snakes, and it's not really a perceived animal in the society. And most of the times when we go to talk to them about snakes, they don't really let us into the communities. So we are using social science cues, we are using anthropological data that we have, and we are dramatizing snakes less and creating an environment in a way that people don't perceive snakes as enemies. Not neither do we want them to fall in love with snakes. We just want them to understand how to ignore these creatures and be coexistent. And that's the midway that we've been working right now, and that's so far been, I wouldn't say too successful. It's a huge population that we are working with, but definitely our failures so far are helping us to make better and better outreach models. And yeah, so I couldn't put a presentation due to lack of time, but all I wanted to add is to the efforts that the doctors are putting up, and of course several researchers, that uh, as a team, I think as a community, this snakebite fraternity is working holistically. It's not just unified in a certain force, and some of us act as the endorsers for the science which is being developed by maybe Venomics or by doctors. If there is anything specific, Jose, that you would like me to answer, I'd like to correspond.
Gani, thank you very much. We'll come back to you with questions, but such promises, such promising, final talk that you and the team is this the kind of people who take it to those villages which we talked about in the beginning. We heard about tribal villages not getting the correct messaging, or the Serpent just talked about their community is not aware about snakebite medicines available. So that's what is needed, and this was what was addressed or talked as one of the challenges. Yani, I know what you guys are doing, and very happy to be part of it, and you know to be associated with you guys for your programs. So that's what we need, the kind of outreach and understanding how people will react to snakes and snake bites, the stigma associated with you cannot just go and talk about snakes. So it's a social challenge, but the way which you are addressing it, and also the using the rescuer network. Unfortunately, we all started our snake career as rescuers, and the kind of reckless rescues which probably we all have done without much of knowledge, much of understanding. Sometimes I really let me confess that the kind of rescues which we started with probably would have was enough to put our photographs on the wall with a garland around it long back, but fortunately we survived. I never got bitten by a venomous snake, thank God, and some precautions which we took. But the snake rescuers today across this country are actually becoming educators. The Sarpa model, which you talked about in Kerala, very happy again. The initiative by health department, forest department, doctors, and the volunteers. Today we have about 800 plus rescuers in the state who are actually educators, first line responders. Like if there is a human snake conflict, these are the people who will go to houses. These are volunteers who will go to each houses and rescue snakes. In the last 4 years, they addressed about 36,000 human snake conflict situations. So these are positive efforts. These are positive moves by state forest departments, health department, tribal department, and doctors. It's a collective effort to reduce the snakebite mortality, snakebite morbidity across the country. So please don't think that on snakebite today that we are talking about um, the doomsday ahead. No, we are actually talking about the way forward. The future looks much better. We have better antivenoms coming out. We have manufacturers there. We have a number of doctors across the country who are committed, and we do have active participation from the civil society, NGOs, individuals who are working as part of the national team to set examples. And with this, I would like to invite Dr. Rajiv from BSV to give the closing remarks for the online session. But at the same time, please don't go away. I know there are a lot of online questions. Dr. Rajiv is just wrapping up the panel discussion, and soon after we will take online questions, which I have a list of questions there. Over to you, Dr. Rajiv.
Thank you, Jose, and I hope I am completely audible and the voice is clear.
Yes.
It's a privilege to be in the panel of a galaxy of eminent speakers, and actually speechless to say, because the kind of presentations or deliberation which have happened in last 1.5 hours, it has been absolutely, uh, I mean, as I said, I speechless. From the policy to the government, central and state government initiatives, to the research that's happening, and now the interventions that's taking place, it's absolutely amazing. Now, I think on a pharma, or so-called the BSP front, if I have to sum it up all, I would rather say that it's all about fundamentals, four things that we can collate into, and that's into it's all about four A's. That's awareness, access, adaptability, or so-called acceptability. When I heard Dr. Shivastava saying it's about a trust, and trust on the right treatment, right dosing, and last but not the least, it's one factor that drives us all towards one common cause. That's an agility, or the timing of addressing this very disturbing trend of the snake bites, if you have some case or an episode. um, on part of the BSV, I would say that most of the stumbling blocks, for example, the remote locations or rural areas, the stigma, the alternate healing, and the geotagging issues that we come across, I think we are trying our best to take smaller milestones to ensure that these are addressed in our own small ways. Uh, as Dr. Saswato mentioned, that it's almost a 2.5 decades that we are in this segment, and almost reducing 1.1 to 1.2 million dosage. That means almost 40,000 cases of the treatments we ensure that happen annually pan India. um, and how that is done, I will bucket it into two. One, it's more face to face or physical. We have a very highly talented skilled field force, or almost 125 people, who have an access or reach to almost 10,000 physicians. We cater uh, to almost a distributor network of almost 700 distributors, or so-called almost 80,000 to 100,000 retailers, to ensure that this product is readily available to the best of our capability. In terms of the awareness programs, I think what we do is a lot of participation in continuous medical educations. Almost 8 to 10 pan India, we ensure that we drive in various medical colleges, or some community of practice audience. Also, we ensure that we have a larger platform representation in leading Indian congresses. To name a few, I think it's APCRI or Gujarat Ecological Education and Research, And very recently, DGHS for northeastern states are a couple of examples that if I were to speak so. And more than that, a lot of in-clinic discussions, awareness, and education that our team directly gets engaged with the physicians. As I mentioned, almost 8 to 10,000 pan India. Coming to the last point, what is changing and how BSV is ensuring that a better awareness or better augmenting to ensure that this segment or this area remains touched even through digital. We have worked, on a very, I think, differential uh, app, which is Serpent, and thanks to Joe's, with whom we have collaborated and work extensively, I think this app provides, I would not say one-stop solution, but almost everything possible. We are trying to gather uh, education first. It lists down species of snakes, almost more than 200 species of snakes, about them, getting educated, the do's and don'ts, and the first aid. I saw one of the questions from the audience, what are we doing for the first aid? This app provides that answers. This app also provides a list of rescuers, and most importantly, I think this app ensures the geotagging or the availability of the ASVS across multiple centers, or the cities, or the channels. So as I said, a smaller step and a smaller milestones to begin with. Futuristically, I think we stand committed to serve patients better, ensure a right access to the people who need it in terms of various initiatives. Reaching out to the schools and colleges is our another endeavor. It may take some time, but we are already have a thought process to get into this. And I think that's it from BSV. About the futuristic research, Dr. Saswato has already addressed. And one thing we will ensure that the quality, the affordability are within the reach of every deserving patient who would need it, and will ensure that how best we cater to those calls and the needs requirement. So with this, as I said, thank you so much, Jose, for this fantastic moderation, and it's been wonderful hearing to the such a eminent experts of panel on the platform. Thank you. That's it from me.
Th- Thank you, Dr. Rajiv. Good to hear from you and the commitment of the company providing anti-venom and the associated services. So we have a number of questions. I'm clubbing few questions. So we have a number of questions about the first aid. What should be the first aid? What is the most proper first aid? I'm not asking any particular person to answer this. I have a number of doctors here on the panel. So any of the doctors who are interested in talking about the first aid during a snake bite emergency, over to any of the doctors who are in the panel. Whomever comes first. Well, I don't have a volunteer, but maybe may I ask Dr. Jaideep if you are there, doctor? Am I audible? Okay, Dr. Jaideep is not there. So then I will go to Gani. Gani is our outreach expert. If
Yeah. I think it's one of the things that we are often asked here at the communities is for first aid. That's the first question, and it is disappointing to tell them that there is no medical first aid. It's not like you could eat a tablet or take an injection and be okay with it. So what we tell communities is, of course, is first, which is basically make sure that the person is in a stage of calmness, so that there isn't too much flow of blood in the body. And then the second thing is remove all the obstacles that the site of bite or around the site of bite that the person would have, such as rings, bracelets, watches, so that there is no prevention of while the hand swells or while the limb swells, there isn't an obstruction. Third thing is we tell them what not to do, because that's very important. People have a lot of misconceptions in their head. So we tell them that do not cut, do not suck, do not try to squeeze anything out, do not tie anything that is really tight. While some practitioners encourage the art of tourniquets, we don't really recommend people using tourniquets because it's often that people don't understand the concept of tourniquets and they don't know what's pressure of certain categories are. So we ask them to keep the limb immobilized, ensure that there is less movement, and call for help, which is a very important thing that people don't often realize, is that you need to call for help because it could be that a victim could always go on their own to hospital, but on the way they could always collapse or fall. And then always use, as much as possible, use a medical vehicle such as an ambulance. But if not, whatever access, the vehicle that you have access to, that victim should go. And I believe these are the critical first aid that we could tell. And I suppose that these answers don't really often qualify as first aid by the community, because there are several ways of the way that community sees first aid. And but still, we insist that this is how it is because there isn't any other option apart so far.
Thank you, Gani. Yes, unfortunately, snakebite does not have any immediate medical remedies as first aid. We have to immobilize the patient and get him to the nearest hospital with antivenom. That's what it's a simple most first aid which is possible, that you reach the hospital without panicking much. I have a couple of other questions. Dr. Karthik, are you there still?
Yeah, I'm here.
Very, very interesting question to you. Which is the most venomous bite possible? Of which snake is most venomous bite? Venomous. So you can give your
Whichever
elaborate.
bites, whichever
Over to
bites you
you.
first.
Over to
Whichever
you,
bites you
Karthik.
first is the most venomous. Well, on a serious note, I think the scent crate in India is the most toxic, at least in our country. We have found that it takes very little amount of venom to kill mice. But yeah, in the world, I think it's inland taipan, both in terms of the amount of venom as well as the potency.
Okay, let me ask one more question from my side to make viewers understand a little bit more about the situation. Karthik, I think, I mean, it's not a question but a statement, that any snake which has got potent venom to kill you is a venomous and a dangerous snake for a human being. I mean, don't don't wait that, oh, this is a syndicate, or this is a baby cobra. So what is your response to people's mindset about, the common misconception is that king cobra is the most venomous snake, or scale viper is not that venomous. The size and the relation of the size between the venom and the potency of venom, how people think about it. So do you have a comment on that?
Yeah, I think I mean, we have all seen comparisons between king cobra and spectacle cobra, right? That king cobra is so big, it produces so much of venom because the venom is not as potent as a spectacle cobra. That's why it makes it in terms of the amount, right? But in reality, when we did this study and published a couple of last year, I think, we actually saw that king cobra venom is as toxic as a cobra venom, although it produces loads of it. So there is no difference in, there is no correlation with respect to size and the potency of venom. As I said in my talk as well, Russell's viper, baby Russell's viper, which are just born, they can have twice as potent venom as their, fully grown adult mothers. So there is absolutely no relation between the size of the snake and the potency of its venom. The potency is dependent on what the snake feeds on, right? If it feeds on mammals, then it's likely that the venom is also going to be dangerous to a human. But if it feeds on birds or amphibians mostly, then very few snakes actually have those kinds of venoms that can still affect mammals, including humans.
Okay, thank you, Karthik. Your insights about you know um,
Yeah.
snakes and the snake venom. My question is to Shashwat. We talked a lot about polyvalent antivenom. What is the strategies? How are we going forward with the current polyvalent antivenom, and what are the strategies?
Yeah, thanks, Jose. I think I have tried to cover. So the current standard of care is, of course, the polyvalent anti-snake venom serum, and which is available as part of the mainstay of the care for the any snake bite management. But I think if I just only restrict to the polyvalent serum, I think we have to be more specific towards the antivenom develop based on the species which are more regional specific. Dr. Karthik has covered, that there could be the antivenoms which could be more specific, lab based, and not harming the current way of manufacturing, like with the equine sources and this thing. But these are all futuristic. But based on the practicality and the available options, probably we can look for as a next step that the sourcing of the venoms from the regions, and based on these venoms the antivenoms has to be produced, which will be probably more effective and more specific to the venoms which are present in the region. Again, with a caveat, like that the snakes do not follow any boundaries, political boundaries, or the geographical, or the country specific this thing. So that the neighboring countries like Bangladesh, Burma, or Northeast probably have the similar pattern. But and similarly in the West, if it is something from the Afghanistan or Pakistan, or the same thing which will apply to the our the northern and the western states, like Punjab or Himachal or Kashmir, or for example Rajasthan. So but I think that's the way forward, at least till the time we have the new options available, which are more specific, monoclonal, or something which are more lab based options which can be prepared. Probably that will take place from the current way of management to the future way of management. No, you are
Unmute,
in
sir.
mute. Yeah, yeah.
Sorry.
Yeah, no.
Is Dr. Amesh Bhardi there? I would like to have a question for him.
Yes, I'm here.
Doctor, we talked briefly about the challenges of climate change, in especially a place like Himachal, where you are seeing impacts of climate change and the, the unexpected species of snakes there. So, what are the challenges you are facing when you are interacting with the communities about climate change and snake bite, and outreaching with communities and the availability of antivenom? Like as a policy maker and implementer at state level, who is leading the state's response to snake and dog bites, what are the challenges which you face there?
See, we found Central Asian cobra in the glaciers of Chamba that remain frozen for 6 months under the ice. So it was a surprise to not only to us but the entire team of UK and other herpetologists how this cobra, Central Asian cobra, survive below the snow for 6 months under the pass. So and when we tested its venom with the antivenom, even not less than 50% was being utilized as cross activity. So we could get hold of this Central Asian cobra in that area because we went to the one of the traditional healers. So he has picture of that cobra garlanded. So we said, "What is this? What snake is this?" He said, "I don't know, but if I could not have been under the ventilator for 1 month, I this garland could have been the photograph could have been mine garlanded here." So you can imagine even traditional healer putting up this garland to Central Asian cobra because he was bitten by that snake and could not save himself. That is the story of traditional healers. So what I find is that very difficult to treat such snakes which has been cross boundary and coming from other geographical regions, and I think climate change has a lot to play in this migration. Over to you.
I think I was connected for a moment. Hello, am I audible?
Yeah,
Okay.
you are audible, of course. Yeah.
Thank you. Yeah, thank you, Dr. Bharti. I could not hear the last part. I got briefly disconnected
Yeah.
for
So
a moment.
what I was saying was that cross boundary migration of snakes due to maybe most probably due to climate changes is another area that is neglected, and we need to put into a lot of studies into that, and then neutralization of their venom by the current antivenom of the current existing country. I think a lot of intersectoral, intercountry research into the
Sure.
venoms need to be there, and Thailand has a lot many lessons to tell us how to make a pan specific antivenoms. So we need to learn from Thailand.
Okay. Thank you, Doctor. My question is again to Karthik, because there is a lot of interest coming in from the audiences. People are asking, what more can we expect from you about the venomonic studies? You already gave a lot of interesting thing, but what's the future? Can you just summarize it for all of us? Give us the good news, Karthik, if you're there.
Joe's Karthik is not here in the screen currently.
Okay. Oh, we lost Karthik also. So there was a problem in between. I think disconnection in between. Thank you, everyone. Thank you, everyone, for participating. People who came as panel members. I know it went a little beyond our stipulated time, but that happens when you have a very active discussion. Thank you, each one of you on the panel who shared your knowledge and took time. And let me assure you that this is not just one workshop, but you can see that there is a lot of commitment, a lot of plans going behind this to ensure that these online workshops, which is already we're doing a lot of things on ground, which will be continued. And thank you very much. And with people like Karthik and Gani around, and Dr. Omesh and Dr. Jaideep, who are ready to be there to support in case of snakebite emergency. You all can have a good night's sleep, and thank you, everyone. Stay safe. Good night.
Thank you, BSP. Thanks.
Thank you, everyone. Thank you.
Thank you so much. Thank you so much.
Thank you.